Hi, my name is Dr. Robert Dunn. I'm the Chief Scientific Officer for Clinilabs Drug Development Corporation. And today we're going to have a fireside chat talking about the symptoms and treatment of bipolar disorder with Dr. Leslie Citrome, who is the Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York, and also presently Adjunct Professor at the Northwestern Feinberg School of Medicine in Chicago, Illinois. Welcome, Dr. Citrome.
Well, thanks very much for having me, Dr. Dunn.
So to start, Dr. Citrome, maybe you could talk about what are the syndromal components of bipolar disorder, and perhaps we could start with mania.
Well, bipolar disorder is actually quite complicated, and we often think of bipolar disorder as mainly a manic disorder where people have expansive, elevated, or irritable mood and increased energy. Those are the two core components. They may also have pressured speech and grandiosity. They may actually be psychotic. And we generally picture, bipolar disorder, they have mania, when in fact the predominant syndrome is actually depression, which we'll get into in a moment. But there are several flavors of bipolar disorder. There's bipolar type 1 and bipolar type 2 in our DSM framework, and there are other subtypes of bipolar disorder in other people's frameworks that have been published, 2.5, 3, 4, 5, and 6, the list goes on. But basically, bipolar 1 and 2 are the major ones in the DSM. In order to have bipolar 1 disorder, you must have had a manic episode. You don't necessarily have to have had a depressive episode. So that makes us think, well, it's a manic disorder, but actually it is not, as depressive episodes are actually more common. So mania, elevated, expansive, irritable mood, along with increased energy, and very often people can describe that they haven't needed to sleep for a few days. There was no need to sleep. They have a lot of thoughts in their head. They have a lot of things to say, and they're pressured. And sometimes they think that they are, somehow in grandiose in ways that they think they are, president of the world, so to speak, or have control over things that they do not.
With depression, as you mentioned, it is the predominant mood state in bipolar disorders. Maybe you could talk a bit about the symptoms of depression and how they're sometimes different from major depressive disorder.
Yeah, this is where it actually gets more interesting clinically, because everyone can recognize a manic person. They're pressured, they have a lot of energy, and they have no insight into their illness, that they are actually quite grandiose, and they can be quite impulsive. And acute mania is generally treated in a hospital because it's very difficult to manage someone who's acutely manic as an outpatient. Depression's another story, and that's a common presentation for bipolar disorder. In fact, the first mood episode that someone with bipolar disorder can have is a depressive episode, which makes diagnosis quite challenging, right? Because they've never had mania before. So the depressive episode is similar to a major depressive episode that you would see with major depressive disorder. However, there may be some differences. Some key ones include age of onset. So typically someone with bipolarity would have a younger age of onset of their mood disorder than someone with plain vanilla major depressive disorder, and it wouldn't be uncommon for someone with bipolar disorder to present in their late teens, early adulthood with a depressive episode. That depressive episode may be characterized by having an abrupt start. In fact, that's not unusual, which is a little different than the plain vanilla MDD episode, which can be more gradual. There can also be some repetitive or recurrence of the depression over a discrete period of time, which seems kind of odd, where they would be full-on depressed and seem better, then full-on depressed again in short order. They may have atypical symptoms, like instead of having difficulty sleeping too much, and instead of a decreased appetite, eating too much. So we used to call that atypical depression, but it may be indicative of someone with bipolarity, as we say. Now, when we look in cross-section in our office in someone who presents with depression, and if you look just at the DSM diagnostic criteria for a major depressive episode, and you use a rating scale like the PHQ-9, which measures the 9 symptoms of depression that are outlined in the DSM, you may come up with a very similar idea or impression: the person's depressed. And the only difference between bipolar depression and unipolar depression would be the past history. So it can be very tricky. And here is the problem. If we make a mistake and call someone who has actually bipolar depression as having unipolar depression or plain vanilla major depressive disorder, we'd be inclined to prescribe an antidepressant, such as an SSRI. And that would be a mistake for someone with bipolar depression, because in those instances, SSRIs will not generally work, and in fact may increase the risk of a problem in terms of making things worse.
Maybe we could talk a little bit about differences between bipolar 1 and bipolar 2, and talk a bit about hypomania.
So bipolar 1 and bipolar 2 often comes into the conversation when we are trying to figure out if someone has bipolar depression or unipolar depression, because it becomes tricky to figure out if they have a history of hypomania. A history of mania is easier if it's documented in the medical record, and it's easier for family members to report because it's usually quite dramatic. Person is manic and not uncommonly in a hospital. Hypomania is different. Hypomania is having symptoms of mania but not quite resulting in the degree of functional impairment that someone with mania would have. They may have some alteration in their functioning, but it's not terrible. They may think they're functioning actually better, but their coworkers and family members know better. They're a bit off, but basically they can still keep it together. They also are outpatients by definition. The moment you require hospitalization for hypomania, you change the diagnosis to mania. That's an automatic switch there to mania. If you're psychotic or have psychotic symptoms, more precisely, then you have mania, not hypomania. So hypomania is having manic symptoms that do not result in the functional impairment that mania does not require hospitalization, and is not associated with psychotic symptoms. So as such, what does a hypomanic person look like? Well, they look like someone who doesn't need to sleep very much and full of energy and maybe a bit scattered, but otherwise, they can pass as not too off until they are. And they may experience depressive episodes. That's what brings them into treatment. And they'll tell you they feel depressed. They'll have no notion that their hypomania was pathological. And they have no insight into the nature of their hypomania, other than that's how they normally would feel when they're feeling good. So in order to get at the history of hypomania, you do need generally a third party to tell you, like a parent or a spouse or a sibling, who could then describe the behaviors that are characteristic of hypomania in their loved one. And that's the way to get that history. Once you do, then you know it's bipolar type 2. No history of mania, but a history of hypomania, and they present with depression.
Thank you, Dr. Citrome. Maybe you could talk a little bit about the mixed features specifier that has been introduced in DSM.
So in order to complicate things even further, we have bipolar type 1, where you must have a manic episode, bipolar type 2, where you must not have a manic episode, but you must have a hypomanic episode. And the most common presentation for bipolar disorder in general will be major depressive episodes. Now, if that isn't complicated enough, we have something called the mixed feature specifier, which means if you have a major depressive episode, you have a certain number of also manic symptoms simultaneously. Now, this makes us think, okay, we're not dealing with plain vanilla MDD. We're clearly dealing with the bipolar spectrum here. So it is actually quite useful in helping us identify someone who is bipolar, presenting primarily with depression. But there's another side of the coin here, in that you can actually have major depressive disorder, present with a major depressive episode with the mixed feature specifier, and technically you don't have bipolar disorder, but you do have something different. You're presenting with a major depressive episode, and there are some manic symptoms there presently, which makes you different. I would treat that person as if they have bipolar depression, not as if they have unipolar depression, because they do respond differently to medication. So it is a complicated overlay on the major depressive episode. Now, there is another twist to the story, too, and I apologize for our listeners if I'm going all over the place here, but that's the nature of bipolar disorder. You can have a manic or hypomanic episode with the mixed feature specifier, which means you are manic or hypomanic and you have some symptoms of depression. That's certainly possible. In the old days, we'd have something called the mixed episode. This was when you had met the criteria for a manic episode and a major depressive episode simultaneously for at least a week. Generally, you would be in a hospital and you would be treated for your mania and at the same time recognize you have significant depressive symptoms. Now, that went by the wayside when DSM-5 got adopted, and DSM-5 no longer includes the mixed episode, but it does include the mixed features specifier. This is actually important because many of the medicines that we have today were approved in the era of DSM-4 and its predecessors. So we have drugs that are indicated for the treatment of mania or mixed episodes. It's just that mixed episodes no longer exist in our diagnostic scheme of sorts, and we would use the mixed feature specifier.
You've touched on this already, but maybe we could address it more in depth. The biggest challenge in diagnosis with bipolar disorders.
Yeah, the biggest challenge is not when they're manic. That's easy. It's when they're depressed. And there the biggest challenge is figuring out, is it unipolar or bipolar? Having a past history of mania or hypomania makes that diagnosis for you if you have it. But in many instances, we don't. And in some cases, we don't even have a third party to ask. We could sort of figure things out if there's a past family history of bipolar disorder. That would lean me towards the direction of bipolarity. Age of onset, number of episodes also play into this. The number of comorbid conditions, both physical and psychiatric, is higher in people with bipolar disorder than unipolar depression. So that is helpful in making a distinction. The atypical symptoms can also help. And ultimately, if they're not getting better with a standard antidepressant, it's either I've made the wrong diagnosis or they have treatment-resistant depression. And more likely than not, I've made the wrong diagnosis. And what is going on here is they actually have bipolar depression that would not be expected to respond to an antidepressant. Now, that said, roughly 15% of people with bipolar depression can respond, but that means 85% do not. A very small percentage of people with bipolar depression, when exposed to an antidepressant, actually flip into mania. But it's a very small percentage, so the risk is not terribly high. But if you think about what that risk entails, becoming manic, then it's something you will never forget should you encounter it in your clinical experience, because induction of mania is rather unpleasant for all concerned. So that's the biggest challenge in the differential diagnosis, someone coming to us with depression. Now, this is actually quite common, because when we count up the number of depressive episodes compared to the number of manic episodes in someone with bipolar type 1, it's 3 to 1. So there's a higher likelihood of being depressed than manic. If you look at the percentage of time over a lifetime that someone is symptomatic, it's about half their lifetime, and the bulk of that is in the depressed phase of the illness. So more likely than not, they'll be depressed rather than manic, and when they come for treatment, more likely than not, they'll be depressed. With bipolar type 2, it's even more skewed in the direction of depression. There have been estimates as high as 39 to 1 for the ratio of depressive episodes to hypomanic episodes for bipolar type 2. And in terms of lifetime experience with the disorder, again, about half their lifetime will be symptomatic, and the bulk of that, obviously, depressed. It's always puzzled me why so much of someone's lifetime is in a depressed phase of an illness, and I can only wonder if it's because they've been misdiagnosed and have not received the treatment that is specific to their type of depression. So I would suspect they've been depressed for longer until the right diagnosis is made, so that more of their lifetime being symptomatic is what it is today. Now, there is some urgency to making the correct diagnosis, because if you don't, you'll give the wrong treatment. And then if you look at the suicide rates, both attempts and successful suicide, they're quite high for bipolar disorder, higher than for unipolar depression, and highest for bipolar type 2. And I can't help but think that maybe it's because they're not being diagnosed accurately and they're not being offered a medicine that would actually work for them.
Thank you, Dr. Citrome. You've touched on some of the treatments for bipolar disorders, but maybe we could turn to the various phases of the syndromal components of bipolar disorder and treatments for those components.
So there are basically three kinds of treatment approved by the FDA for bipolar disorder. The FDA has divided bipolar disorder into three parts: depression, mania or mixed features or mixed episodes, whatever you want to call them, and maintenance. This is different from how the FDA has now approved drugs for schizophrenia, where if you have the indication for schizophrenia based on an acute study, you're deemed to be approved for the treatment of schizophrenia, and there's no distinction between acute and maintenance, although companies will do maintenance studies. For bipolar disorder, it's quite different, and companies who want the specific indication need to show evidence for that component of the treatment of bipolar disorder. So consequently, we have loads and loads of treatments for bipolar mania. We have antipsychotics, the second generation antipsychotics, a fair number of them, I believe most of them. And we have lithium and valproate and carbamazepine. And that is for acute use. Maintenance use is different, requires a different kind of study, and there are relatively few choices there. There are second generation antipsychotics, and there's lamotrigine. So lamotrigine actually is not approved for anything other than monotherapy for maintenance, and it's often used for other purposes, of course. But we have an ample choice for maintenance treatment, and we have an ample choice, as I described, for mania. What we don't have are many choices for bipolar depression. We have basically 5. They're all very different, one from another. 2 of them are approved for also bipolar 1 and 2. The other 3 are not. 2 of them are approved for use with lithium or valproate. The others are not. So they are different in terms of the specific indication for bipolar depression. But that's it. That's only 5. And of those 5, they're all atypical antipsychotics. No SSRI, no SNRI, no classic antidepressant is approved for bipolar depression. Lamotrigine is not approved for bipolar depression. Only these 5 atypical antipsychotics. So if you look historically at them, we have a olanzapine fluoxetine combination, kind of an oddball in there because it includes fluoxetine. But that was the very first one that came out, and that brought to our attention the need to make a careful differential diagnosis, because finally we had a targeted treatment. We have quetiapine, both immediate and extended release, and we have lurasidone, and we have cariprazine, and we have lumateperone. That's it. 3 out of these 5 are now generic, and I would dare say they're more commonly used because they're easier to access. For a long period of time, we only had, the 2 generic options, olanzapine fluoxetine combination and quetiapine, which stymied us because they were associated with side effects that were problematic, particularly for a depressed person. So waking is one of them, sedation is the other, and no one who is depressed and already slowed down wants to be more slowed down. So when lurasidone got approved as treatment for bipolar depression, bipolar type 1, both as a monotherapy and adjunctive to lithium valproate, we were very interested in it, and it became well used, even though it was branded, because it offered something really, truly better. Cariprazine was the next one to become approved for bipolar depression as a monotherapy, and provided another consideration that could be used. And most recently, lumateperone was approved, which can be used for bipolar 1 and bipolar 2, like quetiapine, and along with lithium or valproate or alone, like lurasidone. So these 5 are our choices. They're all quite different in terms of their tolerability profile. I would consider efficacy to be in the same ballpark. So when I looked at responder rates, for example, and I calculated number needed to treat, looking at the individual studies that measured how many patients needed to be randomized to the study drug compared to placebo before expecting to encounter one additional responder, as defined by 50% or greater improvement on their Montgomery-Åsberg Depression Rating Scale total score, they're all in the same ballpark. They're not identical, but they're 95% confidence intervals, which tells us, where the precision of this efficacy effect size is. They're all kind of the same. So I'm pretty good about that. I feel good about offering this, but what they do differ on is their side effect profile by a lot. So I would say we all are aware that olanzapine is associated with weight gain. So olanzapine-fluoxetine combination would be the same, as well as some degree of sedation. Quetiapine, kind of similar there, but the sedation somnolence is actually quite substantial. Lurasidone is associated with some akathisia, particularly at the higher doses, as is cariprazine. But lurasidone and cariprazine are not particularly sedating. Lumateperone is an interesting option there. There does not appear to be much, if any, in the way of weight gain, in that the percentage of patients who gain at least 7% of their body weight was actually 0, which is quite impressive when you think about it. And it's not associated with movement disorders like akathisia or drug-induced Parkinsonism or dystonia, so that's good. But it is so associated with a degree of sedation. Not quite as much as with quetiapine, actually not nearly as much, but it's still there, more so than cariprazine or lurasidone. But I'm quite grateful for it, offering me a different option there. Because you know what? Our patients have different degrees of experience with these drugs and their side effects. I've had patients tell me they're very sensitive to sedation, others are not. I've had patients tell me they're very sensitive to akathisia, and others are not. And I've had patients on drugs that are supposed to create a problem with weight gain, and they have not gained an ounce, and others who have. So patients are different, and the interpatient variability is just simply tremendous in anyone's clinical practice. So I like to have a wide array of options to consider to offer them that suits them, that is the best match for them.
Thank you, Dr. Citrome. And thank you very much for joining us today for this fireside chat on bipolar disorders and your expert information on the symptoms and treatment of these illnesses.
My pleasure.